So we, in our agenda, we now have 55 minutes for 7 groups to each present their high priority items. I'm good at arithmetic. That's about 7 minutes per group.
So we came up with 4. The first action item we discussed was working on provider training for clinicians and staff around cultural sensitivity and humility training. And we had some sub bullet points around creating an accrediting organization that kind of puts their stamp of approval on, providers and different organizations. And then also sharing evidence-based training and training best practices within the health community, so that, all organizations are serving patients with the same practices. So that was our first action item. The second one is to determine the highest priority need of each of the separate communities within the LGBTQ community. The third action item is previously and currently incarcerated LGBT folks and helping with their needs and improving their health outcomes. Sorry, I didn't write that down very nicely. And then the last action item is social media campaign to take advantage of mentorship, education, and creativity within the community.
Thank you. Group 1. Those are our priority items. Group members, thank you very much for all of your input. Can we move on to group 2?
Can you say a little bit more about, I'm sorry, can you say a little bit more about the last one? That last point? Is that?
Yeah, okay. I would paraphrase Benji, and if you can add a little bit more. I think we should have started it with mentorship. That I think that was the key piece, that there be mentorship programs, opportunities, partnerships established, and that some of that might not be through face-to-face means, but even TikTok was suggested as maybe there might be influencers in the community who would take on a mentorship role of sorts as a TikTok influencer and help to reach out to and mentor and help educate the community. Benji, did I describe that okay, or do you want to add to that?
No, you described it very well. I think the team helped me really focus it too, and a name popped in my head, or a visualization was Dr. Ruth, who provided sex education when I was younger on TV and would answer pretty much any question that was presented to her. And that was the awe of her TV shows, this little old woman answering sex questions. And I think we miss that in this day of age. We don't have a Dr. Ruth when it comes to health. And I think the LGBTQ plus community would appreciate that. It's difficult, that fine line of providing entertainment, humor, and a smile, but also providing really important information regarding cancer screening, regarding smoking cessation, regarding proper diet and drug abuse. I think that could be an opportunity that we may be missing.
Does that help, Haley?
Yes, thank you.
Okay, cool. Group 2, and do they know who they are, Alex?
I don't know. I'm just gonna start calling. Oh, okay.
Yeah,
Go ahead.
Great, thanks.
So thank you to the amazing group. Thank you to Ali for note taking and for everyone's input. So we came up with about 3 to 4. I guess, yeah. I'll just go with what we came up with. So the big thing was an educational tool that is ongoing. So something where we can really standardize that everyone sort of gets the same education that is evidence-based, that is helpful and practical, and that isn't just a one-time thing. It's ongoing, continuous, that people can access, can learn as we develop cultural humility and learn what that even means and looks like. The next big actionable item was a visibility tour, where kind of what LGBT Detroit was doing already, where they're going from area to area, and they're presenting and they're having conversations. And then what Benji was talking about as well, with those interviews and sharing those stories. doing that on a larger scale so we can bring more visibility to this community. So we're not just numbers, we're also people, and we're humans, and we can be reflected in that. Additionally, adding more opportunities for change-making organizations to connect with students and young people. We didn't quite know like what that would even look like or mean, but we said like that was something that was super important as we build connection and intimacy with other people. And then the last point that we talked about was this interdisciplinary partnership where different disciplines can come together and it can be fun. It can just be we're here to just hang out, grab a glass of wine or eat, right, and just fellowship and enjoy each other. And then programming, that's around fun versus just lecturing. Did I miss anything, or does anyone want to add more information or context? Awesome. Thank you.
Wonderful. Thank you, group 2. On to group 3.
So we had great conversations. I want to thank our group members again for all of their input to this. We came up, much like other groups, we didn't come up with 1 or 2, we came up with 4, but we ranked them in the order that we thought about them. So the first was community forums, where we would have members from LGBTQ plus communities, providers and policy leaders at the table, able to exchange information and making sure that any work that we do would be informed by the community. And possible things that might come out of this would be creating toolkits around outcomes from the forum, so that we know that the toolkits are informed by the right people, the people who are the end users of the services, and using the forums as an opportunity for community to share with each other, the LGBTQ community, around a community affirming and supportive providers. So as another way for people to learn from each other, where are good places to go for care. The second thing that we discussed was a working group to create guidelines and policies on documentation and data collection efforts for practice and for research, with a lot of discussion around making sure that we had community input on the terms. The third thing was to create a group to use a collective impact model to draw people together to find their connection to the health of this community and work towards positive policy change using a health in all policies model. And then the last one was reviewing existing standards of practice and modifying them to ensure that they meet the needs of LGBTQ plus communities. Folks from our group, if you have anything that I missed, please don't hesitate to add it now. I want to make sure it's reflective of what we talked about.
On to group 4.
Yeah, I'm hearing a lot of common themes, which is great, because I think that means that what we're collectively hearing the same things. So our group talked about adopting small action steps. We have these grand things like the symposium, but what can we do on a smaller level that each one of us can hone in on? And so it was talked about, well, we can adopt language that is sensitive to our LGBTQ plus population, and like forms, spouse or partner rather than husband or wife, allowing for space for transgender and beyond. And so we were like, yeah, that's a great idea. And then it occurred to us, and so one of our people in our group said, well, that's great. We've had these forms for a long time, but they don't speak to the insurance companies, right? The insurance companies don't have that same language. And so there's a barrier there, there's a gap. And so then we started talking about policy change and advocacy on a legislative level so that it covers all of our payers, rather than having to go to each individual one to adjust their language. So that, again, we started small and it ended up big. And then the other, which I hear a lot, is intentional education. So education. It's something that we've all said so far. But I think that instead of just having that annual education where you're checking off a box, that it's intentionalized, that we have people with real stories that can help pull that empathy out so that you aren't just a number, that you are a person with a real story, and that might help push the needle forward just a little more. One of our teammates said, education is great, but if it's going on deaf ears, then what's the point? And that's true. And so I think that we're missing something in that it should probably be a little more personalized.
Fine.
I believe that was our group. So we had quite a few action items, but we prioritized some and we also combined some. So the ones that we prioritized were addressing social determinants of health in LGBTQ populations, utilizing a quantitative and qualitative survey for the needs of the community. This would especially be reaching out to like the ballroom community and sex worker community. Then we also had healthcare provider training for LGBTQ plus care. And this needs to be mandated, widespread, comprehensive. We also wanted to involve the entire practice and not just the ones providing direct care. So not just the providers themselves, but also the people at the front desks. And within this, we also thought that we needed to figure out specific language. So like LGBTQ plus folks that have HIV have unique needs. We also want to have better evaluation, monitoring, tracking to ensure that there's cultural competent care and maintaining some accountability. We also said that there should be community town halls to discuss barriers to access to services and increasing accountability for organizations to provide inclusive care that are being funded. And then ensuring that communities are aware of pathways for reporting. So reporting anything like not getting competent care, and that there's remediation within organizations that have low quality of care, and that there's actual implications for funding when there isn't inclusive care. And then our final action item was having task forces to increase visibility of advocacy efforts. This includes individuals from communities to advance their advocacy work. Also having more education around health disparities. We thought that this could be done with coalitions around specific populations, town hall meetings for advocacy, and then activities to raise awareness and policies, awareness around policies, issues, and fundraising, which can include walks, meals, or other options. And then we would form a coalition around housing as prevention, need for data to support the demand for greater funds and services, and making sure that we have adequate data to do that. And also trying to collect data to advocate in different ways.
Under group 6.
We also discussed several items and then decided, I may have probably swayed this, but like presenting it in the framework of how do we address medical mistrust and work toward a framework of medical trust. And so in thinking about the provider side of building the medical trust piece, there we have like one systemic point and then working with providers directly. So systemically, the idea of that there's practices that are criminalized right now that prevent community members from seeking out care. So the idea of working to decriminalize things like substance use in pregnancy, that way we're not, deterring people from seeking services, and we're providing a service venue that is more accepting, inclusive, and not stigmatizing. Then when we get to the provider level, looking at developing trainings and the idea that there's not really consistent trainings or competencies across disciplines, but there are some, such as nursing, where there are, So the idea of training development for providers across disciplines that addresses intersectionality. First, before intersectionality, recognizing that in that acronym, like Rick was saying earlier, LGBTQ and then 2IA, you know, there's so many acronyms and identities that fit under this umbrella term that we need to learn about individually. And then when we have these identities in intersecting lenses, really paying attention to the implications of what it means to serve people with intersecting identities and with, you know, unique labels, because there are unique needs and, you know, services to be addressed. Also, in the context of provider training, calling attention to the historical reflections of how we got to where we are as far as stigma, pathology, and working to undo this. Also addressing provider attitudes and bias, and, you know, even without malicious intent, just bringing more awareness to our worldviews that we bring to the table. Developing frameworks of working toward competency, but knowing that that's not always reachable. So living in a framework of humility. And then also working specifically with providers around competencies in how to code and work with confidentiality with services such as PrEP, which is now an approved prevention provision, as well as providing care for things such as hepatitis. Then when we go to this other side of of building medical trust and being able to promote community members accessing services that they absolutely deserve to access, having trainings in, first of all, how to identify training centers that are reviewed as affirming, where people have actively reported experiences of having affirming providers and experiences. Also providing psychoed around how to, you know, address certain barriers with transportation, and finding sites that are more local, and also providing more like agency training in like how to go about changing names and genders on your identity, like on driver's licenses, and building agency there. And those are our major takeaways.
Group 7, if I'm counting right, is next.
We decided to start kind of like small and then going outwards. And so we decided that it would be really valuable to create a database. And so, or an app, for example, where patients can go and realize places that they can go to receive care where it's safe for them. And it can kind of be ranked. So patients can review the places, and there's this availability to see what the community actually thinks about the providers, instead of going and trying and then having this possible fear and these other barriers attached there. And so there is already this kind of database that exists with Spectrum. However, it's not a physical one that is accessible to the community. And so it's more so with exactly like Rate My Professor. And so you would call a specific person at Spectrum who is the coordinator of that database. And so they would then contact you with the specific information, but that takes a lot of capacity. And so it would be easier to have this public database. And so then we looked at providing follow-up after appointments. And so offices need to have some kind of survey or form where patients can talk about how their different needs were or were not met. And so this allows patients to speak up after appointments instead of being in an uncomfortable situation during those appointments if anything does happen during them. And so this follow-up would also extend to when there are referrals, especially during the presentations, and how there could be a possible community resource, some kind of coalition where there is an understanding of all of the community resources that are available, not only to that specific doctor that was referred, but to a network of services and organizations that are available. Because even providers themselves, or even us as individuals, we don't understand fully the all the resources that are available in the community. And so after we talk about on the small scale, we can then zoom out and talk about education. And so we were talking about having education like every other group on all levels. And so that includes not only K through 12, but continuing on to colleges and especially legislators. And so for us, we decided to talk about how reaching the whole population is important. And so everyone understands it, not only the most affected populations. And so with this becoming more common knowledge, it will go a long way to decrease the stigma and discrimination that is occurring. And so having that education also means having an ongoing training or module. And so it would be really valuable to have this reference material for the general population. And so folks that aren't specifically serving just the LGBTQ population. And so it would be anywhere from, you know, cooks and drivers to, you know, those who are in senior living centers and anything like that, just so they know, have this like basic idea. We also talked about how there needs to be policy advocacy. And so professionals in academia can go before committees and provide their expert comments. And so it's important for us to build a reserve so that there are professionals that can go and talk about these issues. And so it also means, you know, providing an aspect of storytelling, not only having it be so clinical and so research focused that we miss the big picture. We have to be creative with it and offer a more creative perspective, you know, included with some kind of art installation or some kind of engaging media. And so in terms of policy advocacy, people do need, you know, these skills to provide testimony. So a possible, you know, half-day training or a quick training module that can be done for professionals would go a long way to have people willing to speak up and build their talking points and present to committees and influence policy in that way. Also, real stories are what can influence policy. And so having this reserve will go a long way, not only to have professionals, but community members that are willing to speak up and talk about the reality of the policies that are being put into place. And so we talked about utilizing National Advocacy Day. And so utilizing that day to have, you know, the morning as a training session and then the afternoon being more so putting it into practice. And we do want to get people involved on all those levels. So storytelling, finding the examples and stories. And so not only looking at the national movement, but also starting at the district level. And so starting small and going to, you know, folks who are at the local government level and starting there so that we can influence policy, because, you know, policy does drive that stigma and it does go a long way to changing, you know, the work that we are doing in the long run.
So I think we've now heard from all 7 groups, tons of really great ideas. Are there any, I know much of what's going to be happening over the next several months will be following up these ideas, turning them into task forces and work groups to start talking about academic community partnerships to work on some of these action items. But I thought maybe if there are any couple of general reactions to the lists or some of these ideas or anything you think is missing before we move towards closing and thanking folks for coming for the day, please, anyone.
I think personally, it was an amazing conversation that should have happened a long time ago. I definitely think with moving forward, we've definitely gotten enough information to move forward with addressing some of the action items that have been identified. So definitely, I want to again, thank everyone for attending, giving feedback, and also just your experience with some of the work that needs to be done within the community.
Thanks, Keith.
I think for me, it was really encouraging to hear the different the different action items, both the ones that overlap, but then also the ones that sort of like were on this huge scale and then smaller scale. And it's encouraging to see and know that so many people are engaged and want to make a difference and make some change. And a lot of like what I kept sort of going back to was the culture specific participatory model that my advisor, Dr. Kipperman, talks about all the time, but making sure that as we develop these programs, it is with involving the people that we're trying to serve, and really understanding what it is that they want and need, and then bringing that to the table. So, you know, sometimes like as we get together and we're like, yes, like we see the need, we know the need, let's do something. You know, we can get to that like that tracked mind sometimes, and so keeping that in mind, I think has been kind of cool for me in hearing from everybody talk here as well.
Thanks, Gabriel. Other reactions or things you think we left out that you want to be sure get considered in our list of action items before we get to working on them?
I would like to say, I think the only thing that I was missing or would like to hear a little bit more on would be maybe people with disabilities, especially that fall into the LGBTQ plus, you know, realm of everything. As being somebody that falls into that category, I feel like they get left out a lot. So making sure to include them as well.
Thank you, Alex. As you pull together the list from the 7 groups, can you add an item to reflect that as well?
Absolutely.
And
Thanks.
Levi, this is Zaire. I think I have a solution. We've been working with the University of Michigan to gather data surrounding the impact of people who are disabled, identify as disabled. And so I'd love to talk to you afterwards. Got some great work here regarding what we've discovered.
And the only reason that I bring that up is just to do like a little bit of conversation and thinking about, you know, we have a lot of situations and a lot of things, but I think sometimes, you know, just those extra boxes that people fall into, and just sometimes those are the people that are forgot about, but also thinking about, you know, just mental health, but also including, you know, just the people who are neurodiverse, you know, and thinking about that as well. So man, I fall into a lot of boxes, so I got to make sure to check them all.
Right on. And we agree with that and support that. Right on, Levi.
Thank you for reminding all of us. It will be on the list. Anything else that anybody feels may have gotten left off that you want to be sure we consider as we put this list of potential action items together?
I want to thank Carrie for putting up the evaluation link. And for those of you who maybe haven't been following the chat, to please go there and fill that out, because we want to make sure these things are in fact really useful to everyone. And so the best way we can do that is to hear from you about the best things that have worked for you. So we appreciate your time in doing so. And thanks everybody for a fantastic conversation today. Really appreciate it.
Yeah, I want to also thank the planning committee, especially our fearless leader, Dr. Haley Thompson, for, you know, she's keeping us on task, as well as Alex, who, you know, cracked the whip and said, look, we got to get this done. Come on in, let's get it done. So I want to thank them both for keeping us together, keeping us on track. And I also look forward to working with all of you all once we've gathered all this data, gotten back together, and you all get these emails that you all, you know, show up and say, okay, let's hit the ground running. So thank you all for showing up, and I look forward to the continued work that we have to do.
Thanks, Dr. Thompson. How about if if Keith and I just say a quick thank you, and then you say the big, the big, whatever final words you want to say. Is that cool? Keith?
Fine.
Yeah, so again, I personally want to thank everyone for attending, giving your feedback, assisting with the action items, and also just making sure that we collectively have understanding to the work that needs to be done moving forward, and getting the wheels rolling. So again, thank you. And we'll definitely be in contact with you all once we debrief and have conversation with what we discussed today.
Thanks, Keith, and want to say thanks to Keith and the whole planning committee. Alex, really keeping us on task, as several have said, but you know, and a bunch of the exciting ideas like icebreakers by Zoom, and yes, we can really do 7 breakout rooms at one time, 4 sessions. Very impressed with the IT folks. Thank you, and mostly want to thank folks for contributing their time today and energy to these conversations, and look forward to working with you going forward. Dr. Thompson.
Okay. Well, you know, the word that really comes to mind for me right now is generous, right? Everybody has been so phenomenally generous with your time and your ideas and your feedback today, and I'm just really grateful for that. I want to thank Keith and Rick for, you know, taking the lead with the planning committee. Thank you to all the planning committee members. Just so much gratitude there. All our speakers and presenters, facilitators, note takers. Thank you, thank you, thank you. Special thanks to Alex for her diligence and just focus in keeping this all together, as well as to Chris, who has been behind the scenes to help us keep things organized through this Zoom meeting. So let me just tell you a little bit about next steps. So we're going to be taking all the notes and drawing upon some of the recordings, and we're going to put together some sort of report or white paper that kind of summarizes what we talked about here today. I think that's not only useful for us as a group, the group or the people who have been here today, but also we will make it publicly available. So it's going to be available to any university, any healthcare system, anyone who wants to kind of maybe understand maybe some priorities from local Detroiters and from local academics. So I think that hopefully can in and of itself serve as a really useful resource. But our goal, like I said today, is that this is just the beginning, right? So if you are interested in joining an ongoing work group to kind of advance to even among these priorities we've identified, to get even more targeted, even more focused, to advance at least one of those ideas forward, or more than one, depending on funding, because we do have funding through Checkup and our Vice President of Research. So please email Alex, please let any of us know, and then we'll pull together that meeting probably sometime in November, and then we'll continue some follow-up. So again, our goal here is to have impact. And again, these are your feedback today was a really important part of giving us some direction about where we could go next. So again, yeah, thank you all. Take care, everybody.
Thanks, Haley.